So good morning. My name is Mike Patterson. I'm a family physician in Nunavut. I did my practicum there, and as part of it, I did a literature search on, or a review on emergency preparedness and the all-hazard approach as it applies to Nunavut. I'd like to thank Dr. Kim Barker and Colleen Stockley from Department of Health within Nunavut, and all of the profs for putting up with my ever-changing schedule over the last few years. So, as background information, Nunavut has 37,000 inhabitants. They're scattered into 25 different communities, and it covers about 20% of Canada's landmass. By comparison, that's twice the size of BC with 1 or 2% of the population. In the territory, most emergency management activities are not actually within the Department of Health. They fall into another department. So that gave me a benefit that I had a big excuse to be selective in some of the work that I tried to review. The all hazards approach, my apologies for being late yesterday. I believe somebody already went through some of this. Which also makes my job a little bit easier, but the approach is not designed to give you the impression that we can plan for all emergencies with just one plan. The actual intent was to recognize that there's a big overlap between the skills needed to respond to most emergencies. And it's also intended to include other aspects of emergency preparedness beyond just planning, things like training, acquisition of special equipment, those sorts of things. So, my initial plan, or the initial work that I did, I reviewed several current textbooks, or texts on health emergency management, and then I started a literature search, initially with terms like all hazards, emergency preparedness, and response, and additional qualifiers included remote, isolated, indigenous, and Inuit, and I limited all of my articles to those published after January 1st, 2005. So some of the limitations that I found, the structure of care in Nunavut is very different from most other systems that were examined. Things like a lot of the care being provided by nurses, not having roads, not having a structured pre-hospital care system all affected my review. And as well, the way that the term isolated or remote are used in the literature is very different from the way I think of it. Then again, when I walked out of the session yesterday, there were 2 people complaining about how cold it was. So everything is relative. I just got out of a blizzard on Tuesday, so I was fine. So, in the end, I whittled it down to 28 articles, and I'll be perfectly honest, my selection criteria was pretty subjective because it was me and sort of what I figured would be useful for developing our approach. Most, but not all, related to the all hazards approach. So I'm going to go through 3 of the most important themes that I could figure out from this literature review. So Adini and colleagues produced probably the strongest of the articles that I found. They consulted 229 experts in emergency management, developed a set of almost 500 parameters to measure emergency preparedness, and then they went out to 24 separate hospitals, measured each one twice, looking at their overall assessment of the emergency preparedness for these institutions, and then looking at the scores in different areas related to skills and equipment and planning, those sorts of things. So what they found is that there was a strong relationship between knowledge, skills, and standard operating plans and the overall emergency preparedness of a hospital. So if they scored well in one of those three, they were very likely to score well in this expert assessment. When they looked at specialized equipment, having hazmat suits, having the ability to decontaminate during chemical events, having the special isolation pods for Ebola, they found that that was much, the relationship was much weaker. And I did find several other articles that followed this same theme, but most of those were based on self-assessment and weren't as rigorous either in the way that they developed the parameters or the number of parameters that they used to assess emergency preparedness. But the bottom line is knowing what to do and how to do it seemed to be far more important than having this special kit. So another interesting area was what happens when federal or higher level of governments mandate emergency preparedness. In 2001, there was the 9/11 attacks, followed by the anthrax scares, and shortly after that, the US federal government ordered all local health authorities to prepare for bioterrorist events. So two different groups of authors, Lovelace et al. And Hyde et al., interviewed managers from local health authorities and got their opinions on what the effects of these were. Most did admit that the increased funding and the mandated preparedness did increase their ability to respond to a bioterrorist event, but it also led to a decline in their ability not only to respond to other emergencies, but also in their ability to do their day-to-day work. So anytime one level of government is mandating things for another level of government, we've got to pay attention to those unintended side effects. I didn't just skip one, did I? No. Okay. So emergency preparedness in remote communities, I found one article that specifically dealt with emergency preparedness in First Nation communities in Ontario, or in Canada. This one happened to be in Northern Ontario. After the 2009 H1N1 outbreak, which revealed some problems for FINIB, these two authors, Charania and Suji, worked with several reserves in Northern Ontario to help develop their emergency plan. They utilized a community-based participatory approach, and through, sorry, I went too fast, through several meetings and facilitated interviews, they helped all of these communities get plans in place that the community members were willing to accept. And I also found two articles where authors used computers to help develop emergency preparedness. Raz and Jen developed a computer model to simulate pandemic influenza, sat some managers down with their model, and the managers made decisions on interventions that they could make: deployment of medical countermeasures, surge of staff, isolation and quarantine, and looked at the effect. And Gillette used email to run a virtual tabletop exercise where, with 10 of the hospitals that could be responsible if there was a mass casualty incident during the 2010 FIFA World Cup, they broadcast these emails out, got the answers back, and then a week later would get back to them and say, okay, these are your answers. Based on that, this has happened. So I summarized all three articles in this one slide. Basically, we can utilize these research methods and technology in novel ways to improve emergency preparedness, even in remote or isolated communities. So at the end of all this, I formulated a set of recommendations for the Department of Health, and some of them are starting to come out, and I'm done. Yay!
Just as another person who seems to be quite ecstatic about finishing. Some questions. I'll get you, yeah.
Hi, thank you for a very interesting presentation. My first actual grad level paper was written on emergency preparedness in Ontario hospitals, so this resonated very well with me. I know you were talking about taking an all hazards approach to emergency preparedness, but maybe in your research or in your professional opinion, is there a certain type of disaster or emergency that is maybe more likely to happen in Nunavut? Like, for instance, maybe like a meteorologic, like a weather, like blizzards or, stuff like that, as compared to maybe like a nuclear disaster.
Nunavut, or the territory that now makes up Nunavut, is the site of, I think, Canada's only nuclear disaster or emergency.
I did not know that. Thank you.
Yeah, in the late 70s, a Soviet nuclear-powered satellite went down and scattered uranium or plutonium, radioactive material all over northwest, what is now NWT and Nunavut. So, it's just trivia. But I think we have to be ready for a little bit of everything, just because we wind up seeing a bit of everything. We have several mines now in production, and some of them are bringing up arsenic for gold mine, and we're going to be drilling on that later on this summer. So the other thing is that the all hazards approach has benefits for us with changes in staff all the time, and looking at it from the health point of view of how do we resuscitate critically ill people, and how do we do it when it's just one, whether it's 5 or 10 or more. So it works for us.
Thank you.
Hi, Michael. Thank you for your presentation. A group of us did the evidence review for health emergency management with Trevor's class, and one reoccurring theme that came up we noticed was communication, because of the reality that in an all hazards response or in the event of emergency, a lot of countries didn't have the ability to communicate outside of their country, let alone in this case the province. And I think one of our guest speakers that Trevor recorded actually indicated that the hospitals didn't have a way to communicate with any of the first responders or the police, and that was actually one of the main findings, that in the event, what is the best way to communicate amongst all members, because it's an all hazards response which requires multidisciplinary approach to this across multiple sectors.
Yeah, we're screwed. I'm sorry.
Right.
We have, in Iqaluit, we have one cell phone tower, so that's why we're probably the last hospital in the country that still relies on pagers, because it goes up and down like a yo-yo. We do have satellite phones in all of the stations, but they get greatly affected by cloud cover, and so that's a huge problem. And communications in terms of the technical part and communications in terms of risk communications was a huge chunk that to deal with would have taken up too much of the paper, so I kind of ditched that for adding into the report that I put in. But it is a huge problem. We're just now putting a radio into the hospital at Qikiqtani General Hospital to be able to communicate with the ambulance guys. So.
Thank you very much, Michael. Excellent. I'm sorry. There was one. I missed one. Was there someone? One. Oh, yeah. You've not finished yet. There's one more. Where was the? Oh, right. Look what you've made me do. I've got to go. Oh.
Michael, I just want to say great job. I actually was the other person who did the all hazard presentation yesterday, so that was great. I do just have one question, and it's related to, as you probably found, all hazard really relies on an ICS system or an incident command system, and I was just curious from the health perspective if you found that to be a strong piece in the data, and specifically if a public health officer role was warranted or recommended.
Yeah, you mean in having a public health officer designated in the ICS command structure? Yeah, it would depend on the emergency that we're responding to. What we would probably do for Nunavut is have if it was a mass casualty incident, like a discrete incident, say a house fire or something like that, then it would be the chief of staff who would adopt the incident commander role. If it was a public health event, such as a toxic release or a significant outbreak, then it would probably be the public health officer who took that role. It's a moot point because when I was talking about the difference in the system, it's going to be an all hands on deck moment, and we'd probably get public health nurses and community health nurses and everybody involved. So it's really more, just how do we use that ICS model? But that's how we're going to work it out, hopefully.
Okay, so you are finished now. Thank you.